Okay. I'm excited to introduce our next speaker. Thank you so much for your flexibility. I know our time has been different. We really appreciate you coming and sharing the therapeutic that you've been working on with CTNNB1 Connect and Cure. The title of this talk is Small Molecule Efficacious Therapeutic Treatments for CTNNB1. Please welcome Dr. Michele Jacob, Professor of Neuroscience at Tufts University. Welcome, Michele.
Hello, thanks, Effie. I want to first thank Spila and all of the organizers for inviting us and giving us this opportunity to tell you about our work. And I'm also happy to see all of the patient families, and thank you for being here and for supporting all of our efforts. So I'm going to tell you about another therapeutic approach. You've heard of some really exciting progress going on in multiple directions from multiple groups this morning. And I also will say, well, it's morning for me. I should introduce myself, actually. I'm a professor in the Department of Neuroscience at Tufts University School of Medicine in Boston, so I'm on Eastern time. And I think you've heard a lot of fabulous talks today and yesterday that introduce a lot of the major concepts that I'll be sharing with you. So we're looking at predominantly a small molecule efficacious therapeutic for CTNNB1 syndrome. So as you're all well aware, this is a sporadic mutation. It's heterozygote, affects one allele. So you have one wild type allele and one allele that now has this pathogenic variant, typically a loss of function variant. The CTNNB1 gene encodes the protein beta-catenin. It's expressed in all cells of the body. It plays different roles at different stages of development and in different cell types. It's absolutely critical for proper development and function. And insufficient levels of the protein or abnormality in its function, its dysfunction, that is the core molecular pathology of this disorder. And treatment options are currently lacking, and you see that we're all focused on trying to change this to find a safe and efficacious treatment that will help all of your children. And the work in my lab is really focused predominantly on a small molecule approach. We have some exciting data from preclinical studies, and that's what I want to share with you today. So just a little background, you've heard this already, but I'm going to repeat it. So beta-catenin functions, as I said, in all cells of the body. Our work focuses predominantly on neurons, central neurons of the brain and skeletal muscle, because we feel that these are the most relevant cell types for the core features of CTNNB1 syndrome. And in these cells, beta-catenin functions in two pathways that are essential for the proper development and function of nerve-nerve contacts and nerve-muscle contacts. Those two pathways are the Wnt signaling pathway, which you've heard a lot about. So beta-catenin will go into the nucleus and will turn on expression of particular Wnt responsive genes. Wnt is released by activity, and it's an activity-dependent pathway. The other function of beta-catenin is its special adhesion complexes. So when a nerve cell contacts its target, it makes a synapse. And beta-catenin interacts with N-cadherin in neurons, and that interaction links the synapse to the cytoskeleton. It controls the density of synapses, their stability, and their plasticity. So both of these functions are critical for cognitive function. So to gain insight into CTNNB1 syndrome, we have developed preclinical models, two different approaches. We have an in vivo mouse model, and we have in vitro human cell models. And our goal is to understand what are the changes that occur in these cell types in neurons and in skeletal muscle caused by insufficient beta-catenin levels or particular mutations in the beta-catenin or CTNNB1, and then to test for effective therapies. And so we focus a lot on our mouse model that I'll be telling you about. It recapitulates key features of CTNNB1 syndrome in humans. Our mouse shows reduced learning and motor skills. I'll show you that data. And we're getting insights into novel molecular and functional changes to help us understand the pathology, maybe direct us to additional molecular targets. And we're testing multiple therapeutics. Anna described it when she and Emily presented earlier. we're looking at predominantly small molecule treatment. We're also doing some gene therapy, focusing on muscle particular gene therapy, and we're doing a different RNA-based therapy, not ASOs. But today I'm going to be focusing on the small molecule. That's where we've done most of our work. These are the members of my lab that have done the work. So John Alexander is a research assistant professor, and he's done the bulk of the work. We also have many studies before this on beta-catenin, but it was conditional, either knockout or overexpression. John's been involved in all of that. Leanne Vasquez Ramirez and Crystal Lynn are both members of the group that have been working with us on the mouse and now the human cell models. So we generated a CTNNB1 syndrome mouse model where it's a full body deletion of one CTNNB1 allele. And as I said, we're getting novel insights into molecular and functional changes, and we found a small molecule that normalizes the beta-catenin levels in the mouse model and corrects the phenotypes. So proof of principle that this is really a heterozygote or a haploinsufficient mouse model. We've measured the levels of mRNA and beta-catenin protein. We've looked in the brain, 2 different regions, the hippocampus, and you see here in mRNA in the hippocampus, it's reduced about 50%. And then we look at protein levels. We look at hippocampus, frontal cortex, we look at muscle, the diaphragm, and also leg muscle, the tibialis anterior. Beta-catenin protein levels are reduced about 50% in the mouse model. And the mouse recapitulates the features that we see in humans. So one of the tests that we do is a cognitive test. How well does the mouse learn? And this is a very stringent test. It's called contextual fear conditioning. You take the mouse and you put it into a novel environment when it's not in its home cage. It's a novel environment that has a wire floor. And you give it a mild foot shock, and the mouse does not like this. It does not want to be in this place. And you do a series of trials. The blue are the wild type mice. They quickly learn to freeze. They don't want to be in this room. The heterozygote mice don't learn as well. They do improve, but they don't perform at the level of their wild type litter mates. So these are litter mates. Some of them are heterozygote, some of them are wild type. And so this is an associative learning test showing that the mouse does have some cognitive deficits. We've looked at muscle function. We've used the rotarod. This is a test that looks at rotor sequence learning, but it also looks at coordination and balance. This rod spins and the mouse has to use its limbs to stay on, and it falls a short distance. You can see again with multiple trials in blue, the wild type mice improve over time. The heterozygote mice do not do as well. We've measured forelimb grip strength, a sign of muscle weakness. We use this force meter and you pull, and we can see that the mice have reduced muscle strength. If we look at their locomotion in the open field and we measure how much they move or their speed of movement, that's not impaired. So it's not a confound that would affect our other data. We started to define molecular changes. So we've looked at several Wnt target genes in the brain, and we find that several of the Wnt targets show reduced expression levels. A novel change that we found that we think is pretty interesting is this sodium potassium ATPase. This is a transporter protein. And what it does is when cells are very active, and I mean cells that are excitable, like your neurons or skeletal muscle, you get changes in these fluxes of these ions during the activity. And the sodium potassium ATPase is critical for regulating that flux. And we have reduced levels, and that affects the excitability of neurons and skeletal muscle. And the phenotypes, I think, are very relevant. We have a collaborator who's done electrophysiological recordings from hippocampal neurons from our CTNNB1 haploinsufficient mouse, and we're finding functional changes consistent with this impaired function of the ATPases. So how are we going to fix this? Really, that's the goal for all of us, right? So we are focusing predominantly on this glycogen synthase kinase. You've heard about the destruction complex from many speakers. This kinase, like beta-catenin, it's endogenous, it's expressed in every cell of the body, it's constitutively active, it's on, and it phosphorylates beta-catenin, that's a post-translational change. And that phosphorylation, and you've heard about the exon 3 where the phosphorylation sites are, that targets beta-catenin for degradation. So if you inhibit the enzyme, beta-catenin is not phosphorylated, it's not as readily degraded, and it will accumulate. So it's a very well-defined mechanism of action. It's been studied for multiple uses in cancer, in Alzheimer's disease. It's a validated druggable target. And we are working with medicinal chemists who have developed a small molecule series that has the highest selectivity for inhibiting GSK3 compared to what's currently available. And so we wanted to test this and say, is it effective as a potential therapeutic? So we've taken mice and treated them. They're about 6 weeks old, and we treat them with this small molecule for 5 days, one dose daily. And we are able to bring the beta-catenin levels in the brain and in the skeletal muscle back up to the normal range of their wild-type litter mates. We're not going above that range. We find it's really important in our minds to bring it close to wild-type levels. We want to avoid excessive levels because you've heard about oncogenesis, and also from work my group has done where we've conditionally overexpressed beta-catenin in excitatory neurons in the brain and in striatal neurons. We found that mice has learning deficits and autism-like behaviors, and in some cases, infantile seizure types epilepsy. So we definitely want to avoid overexpression. When we treat the mice at this stage, when they are already symptomatic, because we're always using the same age group for the drug treatment and for the behaviors, we are able to rescue not only the beta-catenin protein levels, but the phenotypes. And this is where I think it's really important. So the gray bars are mice now that are heterozygote that are treated with this small molecule. And you can see their performance in this cognitive test, this assay. They are now not significantly different from their wild-type litter mates. They are significantly normalized compared to vehicle-treated heterozygotes. Grip strength is improved. It's not quite wild-type levels, but again, we've treated only for 5 days. The rotarod performance with training also gets improved to the level of wild-type. So we're very excited. We're seeing beautiful rescue. We also see rescue of some of the molecular changes. I'm not going to get into all the details of that data, but we see improvements in Wnt and the sodium potassium ATPases. As a beginning test of how safe this is, we took wild-type litter mates, tested them with the same treatment protocol, and we see no change in their learning or their grip strength, no significant change over the time course in beta-catenin protein levels. So what are the takeaways from the mouse work? We found this small molecule. It's a highly selective, highly specific inhibitor for GSK3. We've done in vivo tests. We can normalize beta-catenin levels. We predominantly normalize the phenotypes. This is a young adult stage. It's a symptomatic animal, so we don't have to start very early. And that's consistent with the importance of beta-catenin and the Wnt pathway and coherent function in plasticity, critical for normal learning and memory. We correct the phenotypes, and so far we don't see adverse effects in wild type. We definitely need to do a lot more studies on safety. So it's great. It works in the mouse. What about humans? I mean, really, that's where we have to go, right? So we've done some tests now where we're showing therapeutic benefits, at least as far as molecular changes in human cells. So we're working with a couple of different models. We are working with, you've heard the definition, human pluripotent stem cells. So this was a healthy human volunteer, did a skin scrape, fibroblasts. He's actually from Europe, and his cells were then turned into these pluripotent stem cells and characterized to have absolutely no pathogenic variants. And then one of our collaborators used this gene editing to make it the cells heterozygous, having one allele of beta-catenin removed. And we use that cell line, and we differentiate those pluripotent stem cells to excitatory brain neurons and to skeletal muscle. We've also started working most recently with CTNNB1 syndrome patient-derived iPSCs, and I'll show you our latest data from last week. So we're using the human cell models to gain insights into the molecular and functional changes. What is shared across all the different patients with the different mutations? What is shared between humans and mice? That tells us the core pathology of this disorder. And then what are the treatments that are effective, and are they effective for all mutation types? So just again, principle, we take our human heterozygous iPSCs, they have reduced beta-catenin levels, we're doing everything at the protein level, and we see about half the beta-catenin protein and 3 different Wnt target genes also show reduced expression when there's insufficient beta-catenin. So what about the therapeutic? So the drug 1 is the same drug that we used in the mouse in vivo, and it was effective. And we tested it on these heterozygous human pluripotent stem cells. And at 30 micromolar, it is bringing the beta-catenin protein levels up to about wild type range, double what we see in a vehicle-treated heterozygous iPSC. Now we're testing a series of drugs that our medicinal chemist collaborators are generating, and the goal is we want to find the drug that is the most potent, the most stable, and gets into the brain most efficiently, because then we can use low doses and we might be able to treat less often and get beneficial effects. And if we can use low doses and treat less often, we think safety goes up. So we have 2 different drugs now that are variants of this first one that worked in the mouse, and they again show really nice rescue at 10-fold lower concentration than our effective drug in vivo. So we're going and characterizing these more and improving the properties to improve safety and to move forward to clinical trials. We want to know, now these are pluripotent stem cells, so we took these human heterozygous iPSCs and we differentiated them into brain excitatory neurons, glutamatergic neurons. And the same drug that worked in the mouse in vivo improves the beta-catenin levels in these human-derived cortical neurons. And we have just started working with patient cell lines, so we have this pilot data where we took one of our patient cell lines and we treated it with the drug, and you see a nice significant increase in the beta-catenin protein levels in this patient-derived pluripotent stem cell. So we're focusing now a lot of our attention on the patient cells. As you've heard from, I believe Emily talked about this, there are several different iPSC lines that are now available. We got them, they're growing in the lab, and we've just started characterizing them. So we just wanted to do kind of like a scan. So there are mutations across the gene. You've heard most of them we think are loss of function, premature truncation. Stephen Sanders gave a beautiful talk about this. We looked at 7 different lines. We have a control that we set to a value of 1, and there are no standard error bars here because each one of these is a value of 1. So this is really a pilot we did last week, just like a survey to start to get a handle on what's going on with the patients with different mutations. And what we're finding in the patient pluripotent stem cells is 6 of the lines show a decrease in protein levels. There's a bit of a range, goes from about 50% to about 75, 80%. So there is a little bit of a range, but as I said, it's an N of 1. You've got to take this with a grain of salt. I'm not showing you line 7. Line 7 looked like it had normal protein levels, but we have data that suggests that actually there is a product and it's a truncation product. And it's been mentioned when you have truncation products, we have to know, does it retain function or does it act as a dominant negative? If you're increasing expression of that, is it going to be problematic? What kind of level of wild type do you need to potentially override the effects of a dominant negative? We want to avoid overexpression and too much gain of function. So our goals are to test the efficacy of our small molecule in several different patient-derived cell lines. Do we have to stratify patients, or will this be effective in all cases? And we're doing a lot more to understand the safety as far as the efficacy. So I think from all the talks you've heard, it's a really exciting time. We have really great preclinical models, both patient-derived and in vivo mouse models. And these studies are essential for defining efficacious and safe treatments. And could be various approaches we're talking about. And I just want to acknowledge the funding for our work has come from CTNNB1 Connecting Cure in the US and from multiple grants from the National Institutes of Health. And thank you so much for your attention. I'm happy to take questions. If we don't do it live, then you can always email me.